Hi, everyone. I'm Michael Paul Shelmo. I'm an assistant professor in the Department of Psychiatry and Behavioral Sciences here at the University of Minnesota. It's my great pleasure today to introduce Dr. Jed ELISON from our very own University of Minnesota as our Grand Round speaker this morning. Jed is currently an associate professor at the Institute for Child Development and in the Department of Pediatrics, and is on the executive council for the new Masonic Institute for the Developing Brain. Jed began his academic career by completing a bachelor's degree in psychology and English at the University of Utah, followed by a PhD in developmental psychology from the University of North Carolina. He completed his postdoctoral studies at Caltech before taking a faculty position here at Minnesota. Jed's research program focuses on human brain development during infancy and toddlerhood. He uses tools including neuroimaging, MRI to understand and predict individual differences in social communication, and his work includes studies both of typically developing individuals and of individuals on the autism spectrum, and with an emphasis on identifying kids that are at risk for ASD. Jed and I first met when I began working on a study with Suma Jacob and Christine Conalia at the Center for Neurobehavioral Development. A couple of years ago, Jed was kind enough to give me an introduction to the eye tracking system that is available at CNBD that his group uses pretty heavily. And from there, I became involved in another study with Jed and one of his postdocs, Cherise Spikran, who I'm working with them to help them analyze some EEG data from a study of face processing in adults and infants. And since I happen to be the father of a 6-month-old baby, I have both a personal and a professional interest in learning more about how the brain develops in the first few years of life. So I'm very happy to turn things over now to Jed and hear his presentation, which is entitled Towards Strategic Prevention in ASD.
Thanks, Michael Paul. I appreciate the introduction. And I'm sincerely appreciative just to be here. I think this is a fantastic group and fantastic opportunity to share some of our recent work with this group. And I should note, I wear a few hats, and I'm going to talk really focusing on the autism spectrum disorder work today. But I like to open with, after I get through kind of this first slide of disclosures and funding and acknowledgements, all of this work wouldn't be possible without very generous funding from NIH, funding from some private foundations as well, including the Gates Foundation, to push some of this work forward. But I generally like to start with things that I'm not going to talk about, and I'm actually not going to talk about the Baby Connectome project and some of the from my vantage point, innovative work that we're doing on infant toddler brain imaging and characterization of structural and functional connectivity across the first 3 years of life. There will be a slide or two on that, but not too much focus. I'm not going to talk about a project that I'm really excited about, where we're studying babies who are born with agenesis of the corpus callosum or who are at risk for developing autism spectrum disorder and other developmental delays. This is a first of its kind study, and we're really excited about and are generating some really exciting data. I'm not going to talk about work that I've been doing over the last 5 years on trying to build a tablet-based eye tracking system to take our research out to hard-to-reach communities. In part because I don't have time today, but also because a few months ago, some Google engineers published a paper that essentially levied all of this work worthless. They solved a problem that we've been trying to solve for about 5 years. And so I'm happy to move on from that project. And I'm not going to talk about kind of broader conceptual work that I do on developmental social neuroscience. But for the curious among you, which I know that there are many, you could take a look at this volume 39 of the Minnesota Symposium on Child Psychology, where we specifically attend to some of these issues. So what is the roadmap today? What am I going to be talking about? Well, I'm going to open with some kind of some information about autism, clinical highlights, some background statistics on epidemiology, and a brief preview of some behaviors that we're particularly interested in. Then I'm going to move to kind of present to the challenge of early identification. The major aspect of my program of research, it seems very, very straightforward, very pragmatic, almost applied. We simply want to improve early identification, identify more children with the explicit objective of trying to get these children intervention services as early as possible. I'll introduce some potential solutions. The bulk will be on these kind of ideas for potential solutions to these challenges that I introduce. And then we'll finish with kind of this idea towards strategic prevention, preemptive intervention in autism. So let's start with autism. If you've seen me present on autism before, you've definitely seen this slide. I really like it, from Jeremy Vinscher-Vanderwill and Randy Blakely. But essentially, for this, for now, we're highlighting these two central nodes, two core symptom domains, social communication and restricted and repetitive behavior. This will come up kind of conceptually later in the talk when we talk about kind of the nature of autism. There weren't always only two domains, and this is kind of a byproduct of kind of evolving thought and was codified in DSM-5. But up until DSM-5, there were three domains where we talked about communication impairments, social impairments with social behavior, and restricted and repetitive behavior. Now, it's important to note that these are kind of broad domains. These are not kind of singular categories either. And when we talk about restricted and repetitive behavior, the difference between, say, insistence on sameness behaviors or rituals or routines are strikingly different from self-injurious behaviors or stereotyped motor behaviors, stereotyped motor mannerisms, which are also highly prevalent and symptomatic of autism. And so it's important to note that while we have these two domains, we should be thinking in more precise ways about kind of the specific symptom profile that we see. And I'll come back to kind of all of these bubbles around the top because they are kind of highlighting the heterogeneity of autism. But for the kind of less initiated, some associated features of autism that are important to note. So there does seem to be this sustaining sex ratio of about 4 males to every 1 female diagnosed with autism. That oscillates. Sometimes we see 3 to 1. If we talk only about individuals with high IQs, that number can go to 9 to 1, males to females. But across the board, we do see this discrepancy. This is another figure that has been, with kind of shifts of prevalence estimates and shifting kind of symptom domains and all of the changes that have occurred in the last 40 years or so of autism research, this has stayed very stable. This estimate of associated intellectual disability has kind of oscillated between 30 and 50% for a long time since we first really started tracking it. I think the first estimates, the first estimates were for the next bullet point, but this is I think some of Eric von Bohn's early work was the most kind of rigorous in estimating this. Among the first prevalence studies was conducted by collaboration between one of my first advisors at the University of Utah and folks at UCLA, a UCLA-Utah prevalence study. And I think that the estimate of associated intellectual disability in that group was around 30 to 50%. So, and then we see from recent data suggesting if you're only looking at 4-year-olds, younger kids, that metric's even higher. Seizure disorders are common comorbidity in about 20 to 30% of all autism cases. And this is the data that goes back as far as the late 60s, 70s to Bernie Rimland's estimates. And the important work that he did kind of establishing autism as a disorder of brain development and of neurological origin. The estimates with regard to kind of comorbid conditions is they vary between high and very high. Interestingly enough, when I started doing autism research, a child with autism could not receive a comorbid diagnosis of ADHD. They were exclusive. Just to kind of give you a sense again of context and how we think about autism. But there are some estimates that associated anxiety disorders are as high as are manifest in as high as 60% of all autism cases. The last bullet point, we do know that individuals with autism have specific strengths. The ones that get kind of publicized and that we see in the popular media, strengths that we might define as savant skills or splinter skills are extraordinarily rare. They do occur, but they are extraordinarily rare. With regard to kind of background genetics, this paper from Sandin and this group was really remarkable and kind of, from my vantage point, it replicated a number of other findings that were out there, but it was fairly conclusive that heritability estimates suggest that autism is about 80% heritable in that range, according to twin studies and family studies. Now, the genetics we're learning more every day. I put in this kind of citation for the interested. If you're interested, it's a really lovely recent review, I think from 2019, describing kind of the background genetics across psychiatric disorders, but also includes what the story that's unfolding is that understanding polygenic disorders is going to force kind of transdiagnostic considerations. And so one thing that is unique about autism in relation to other psychiatric disorders that are covered in this studying in the Psychiatric Genetics Consortium is that rare de novo variation is predicted to account for about 15% of ASD cases. And this is much higher in autism than in other psychiatric disorders. The recent estimates suggest about 1 in 54 children, 8-year-olds in the United States are diagnosed with autism. I'm going to get to a study design where we study younger siblings of children with autism. And we do this in order to leverage the increased recurrence rate. So about 1 in approximately 5, again, estimates vary depending on your kind of sampling frame and procedure, but about 1 in 5 younger siblings of children with autism will receive the diagnosis themselves. And that number goes up according to a recent paper. It's about 1 in 3 in younger siblings if there are 2 or more children with autism in the family. So why the apparent increase? I'm sure people want to know why prevalence estimates seem to be increasing. We have very clear changes in diagnostic criteria. A big change happened in 2000 with the DSM-4-TR that was introduced, and then of course in 2015-13 when the DSM-5 came out. There was concerns that it was going to be more strict, but I don't think that those concerns have been borne out. And so we have great public awareness campaigns. Most people on this call know that April is Autism Awareness Month because we've had great, really important messaging from groups like Autism Speaks and for a long time, and the Autism Science Foundation now, among other nonprofits, autism societies, local chapters, plus the national chapters. We have greater public awareness. We have better case ascertainment, lower age diagnosis. And then we also are seeing a fair amount of diagnostic substitution. Whereas someone who historically may have been, I think the best evidence for this is in California, where a diagnosis at one point of idiopathic intellectual disability, it has been decreasing substantially, and that's correlated with an increase in autism diagnosis. I'm going to share a very brief snapshot. I like to show this video because it shows some of the subtle behaviors that we're interested in characterizing and being able to predict. But it's also, I want to kind of preface this to say, when I started doing autism research, I was led to an autism lab simply due to intellectual curiosity, and my mentors did the best thing possible for me. And they assigned me to participate in some social skills groups. And so I just started hanging out with adolescents with autism. And that was my job for about a semester, was just hanging out. And it was, and it changed my perspective and vantage point. But what, one of the first things that my mentors said to me was, you meet one child with autism, you've met one child with autism. This is something that everybody that knows this area has ingrained. And as scientists, we talk about heterogeneity, and you're going to hear me talk a lot about it. And I think only kind of recently have we really started to elucidate that heterogeneity. So again, keep this in mind. You're going to get a brief snapshot of one child.
Bobby is 14 years old. He borders on high functioning autism and Asperger's syndrome, and he is from my first marriage.
He's very shy. He's a very shy boy. Might be termed as a typical wallflower type, where he just kind of just fades back.
He works really hard. I mean, he knows how to do the most things to help us out, and he's really good at it.
And his big thing is detail. Like, he just will really good do exactly every little piece that he has to do. He'll follow instructions to the T. And so when he's cleaning, it's like he does every last little bit.
Bobby does shoulder a lot of burden in being as the oldest child in this family.
That needs to be done. Someone else needs to. I'm the one. Yeah, I'm sitting the bar right now.
Bobby's focus is grades. He will come home from school, jump on the computer, get on the internet, and he'll look and see how his grades were for that day.
Wow. Oh my goodness sakes, Bob.
Still me, man.
That's really good. Just an A-. We talk about just an A-. Oh, I had to work really hard just to get like a B average in high school. You were super smart, Bob.
Equations on the board, and it says in the first one we're going to solve using.
Bobby's been diagnosed with Asperger's syndrome, which by definition means that you're in the high functioning range.
That's what I say.
Most people with Asperger's syndrome or mild forms of autism are not good at picking up social cues.
Hi, come on in, have a seat.
What I'm trying to find out from Bobby is how he perceives social interactions, how well he can do a back and forth conversation.
Oh, all right. What else do you like to do for fun?
Watch TV.
Yeah? What kind of shows do you like?
SpongeBob.
Oh, I love SpongeBob. Do you have a favorite character on SpongeBob?
Squidward.
Really? That's cute. I have a favorite character on SpongeBob.
Am I supposed to guess?
Most people with autism don't initiate a lot of friendships.
Have you ever had a best friend?
I still have best friends.
Oh, tell me.
When I ask him about friendships, I'm trying to see what his concept of a friend is.
I have some best friends in 4th period.
Yeah?
And there's one kid.
Uh-huh.
He's like the class clown.
Really?
Yeah.
Do you ever see him outside of school, like after school or on the weekend?
No, it's like only in school.
From what he tells me, these kids sound a little more like acquaintances than true friends. I wasn't surprised when he told me about his friends, and then he said, when I asked him more, like, do they come over? I wasn't surprised when he said no, but I also wasn't surprised that he really considered them good friends. I get that a lot from kids with Asperger's syndrome. For Bobby, the amount of social contact he has with his friends right now is probably very satisfying to him, and that's a good thing. The trick is all of his social contact is structured by other people, and when he's an adult and he's no longer at school, he won't have those opportunities.
Okay. So just one piece that I wanted to highlight there. One symptom domain is pragmatic communication, the kind of rules, unwritten rules of back and forth communication and how we share is a pretty high level and sophisticated capability, and is I think of as a future direction for my lab is thinking about kind of the developmental precursors to this back and forth pragmatic communication skills. And we study some of these aspects with regard to sharing attention in pre-verbal communication, but very interested in kind of future efforts to kind of follow the course of these constructs and behaviors into preschool and school age. Again, just a snapshot of one child's profile. And also like to highlight with this video is that Bobby clearly has some strengths, and leveraging those strengths through interventions may build some resilience for kind of future function. Okay, so in addition to functional challenges, there's a fairly complex kind of story around the economics of ASD. There's estimates that the lifetime costs are about 1.4 to 2.4 million above and beyond the cost to rear a typically developing child, to rear a child with autism, an individual. These are lifetime costs. Societal costs, the estimates in 2011 was that it cost about 230 billion, about 260 billion in 2015, and it's anticipated to be about 460 billion in 2025, but there are some pretty broad error bands, and it could go very high in 2025 if changes aren't made. So one last kind of dollar amount that I like to leave folks with is this figure. Early intensive behavioral intervention costs between about 40 and 80K per child per year. But we do know that there are benefits from early intensive behavioral intervention. And yeah, that's the next slide. So this was a paper that was published in 2010. It really got a lot of attention in that this intervention was implemented 4 hours a day, 5 days a week for 2 years. So very heavy, very intensive. The children enrolled between 18 and 30 months. And at the end of the trial, there were striking increases in communication skills. And no changes in autism symptoms, no notable changes in autism symptoms, no notable changes in diagnoses, but notable and kind of striking changes in communication. I should state that they attempted kind of a follow-up of this, a multi-site follow-up, and the findings weren't as clean as this initial trial as you would expect, as anybody kind of who tracks these kind of things would expect. But they still seem to me to be going the right direction. And this group did publish kind of a follow-up. This intervention did seem to kind of normalize electrophysiological activity. And then when they followed them later at age 6 is when they began to see a reduction in autism symptoms. So there appears to be some sleeper effects or cascading effects, however you want to describe them, positive cascading effects from the early intervention. Now, this intervention, again, something that I want to take from you is that timing matters when we implement these interventions. So the same group tried to do something similar with, so this is tried to kind of modify the dose with working primarily with parent-based intervention, and they didn't see any difference in functional outcomes, but they did see that the younger age and more hours improved the outcomes. Another, I don't include a reference to this other paper, but Sally Rogers has tried to downward extend the early start Denver model to a group of infants. Seems very preliminary, but there might be something, some signal there as well. But in older kids, and I think this is important and interesting, where this group in Australia essentially tested the efficacy of ESDM, early start Denver model, before and after 48 months. And what they showed essentially is that if implemented, there seemed to be, it's not exactly straightforward, but essentially the older the kids, at baseline, they had a lower verbal DQ than the younger kids. That might just be part of the process, the developmental process of the disorder. But they clearly did not make the gains in verbal DQ that the younger kids did. And so this paper for us is regardless of how you interpret that, whether it's just this difference in baseline is what's driving the change, or it's just that they're older and kind of more consolidated phenotype. Points to the direction that we need to identify these kids younger and get them intervention at a younger age. Okay. So in order to get more children into early intervention, we need to improve early identification. And we're talking about population-based screening at this point. And the kind of gold standard right now, I think in most clinics, they use something called the Modified Checklist for Autism in Toddlers, the MCHAT. And this paper was published in late 2019 and essentially showed a positive predictive value of 15% for the MCHAT. And more importantly, as important, the specificity and the positive predictive value were lower in children of color and children from lower socioeconomic, lower income households. Okay, so not only does the measure not work when it's not in the hands of the developers of the measure, but it works even more poorly in children of color and children from disadvantaged backgrounds. So this is clearly, and this is the go-to screener. It's a 20-item yes/no screener that's designed to give you a categorical outcome. Yes, you failed the MCHAT, or no, you did not fail the MCHAT. So this is clearly a problem that needs to be solved immediately, because even in our Fairview system, this is what they're using. So the challenge, there are multiple challenges. This should have been a plural in early screening, population-based screening. First is how we conceptualize autism. Okay, so there's this drastic or dramatic or extensive evidence of etiological and phenotypic heterogeneity within the DSM category itself. So the way that I talk about this, and if there's something you take home from this talk, is that ASD, or autism, is not a natural kind. It's not a singular entity or category that exists in nature. It's a diagnosis determined by clinical consensus, right? And I'm going to give you one history slide on kind of context for how that came to being shortly. But so if it's not a singular category in nature, why are we trying to screen for it as if it is? Why are we trying to diagnose it as if it is? Okay. Now, granted, there were some changes in DSM-5 that were important, and we're trying to kind of stratify, add a severity rating to the diagnosis, and I think that's a movement in the right direction. But if we acknowledge that it's not a natural kind, that's going to change how we ask questions about the phenomenon. So this etiological phenotypic heterogeneity. So etiological is variability in cause, and phenotypic is variability in the manifestation. We are also dealing with one additional challenge of early screening. We're also dealing with this variability across the typical to atypical continuum, this kind of fuzzy nature of the diagnostic threshold. And this is a real thing, and what it leads to is the wait and see approach that leads families on diagnostic odysseys, where the clinical response is, let's wait and see. You know, this is really fuzzy. Let's wait and see. And I have some data to show this this phenomenon in a minute. And lastly, a kind of underappreciated kind of source of difficulty here is this variability in phenotypic manifestation over time, something that I've referred to as temporal heterogeneity, and some colleagues and friends call chronogeneity. I actually like their term better, but it's something that we can talk about as well. So the ideological and phenotypic heterogeneity, of course, I already showed this slide. There are hundreds of penetrant genes that have been identified, rare genes that have been identified. We get this kind of cognitive comorbidities where I mentioned, you know, a substantial proportion have co-occurring intellectual disability. And this is a very different case than what you saw with Bobby, who's doing quite well in school, clearly has a high IQ. We're no longer kind of talking about high functioning autism. What we're talking about is, in general, what people meant is high IQ. You can have a high IQ and still have functional impairments that make life really challenging and warrant clinical intervention. Of course, the behavioral comorbidities that we mentioned, medical comorbidities, there's no single diagnostic biomarker that has kind of sensitivity and specificity that's worth mentioning. So it's just evidence, ample evidence of ideological and phenotypic heterogeneity. So variability across the typical to atypical continuum. This is recent data. It was just accepted in JCPP just recently in work by my colleague Birken Tunk at CHOP, and these are findings from the IBIS study, which I'll tell you about. These are infant siblings of children with autism that we followed from when they were 6 months, and this data is until 36 months. And what he's going to report on is this group of kids. So these are all high-risk kids. The purple are high-risk kids who had a diagnosis at 24 months and also had a diagnosis at 36 months. The pink are high-risk kids who did not have a diagnosis at 24 months and who did not have a diagnosis at 36 months. And then we have this mixed group, okay? So the yellow group are high-risk kids who had a diagnosis at, oops, you can see my cursor hopefully, at 24 months, but did not at 36 months. And green are kids who did not have a diagnosis at 24, but did at 36, okay? And so what he did is he used a machine learning technique, support vector machine, to establish a classification plane or boundary. And what you're seeing is the results of that support vector machine here, trying to classify kids as ASD or not at 24 months and 36 months of age. So on the left is 24 months of age. What you're seeing, those who don't receive a diagnosis at 24 or 36, a very small proportion of them are kind of failing according to the classification technique. On the other side, it's classifying most of the kids with autism who are diagnosed at 24 and 36 with that diagnosis. And then these are the middle group, the hybrid group, okay? So the yellow group is a group that doesn't receive the diagnosis at 24, but they do at 36. So it's doing pretty well with them at 24 months. But it's a bit of a split. It's kind of, the mean is right on the classification boundary at 36, which is interesting. And then this group that received a diagnosis at 24, but didn't at 36, they're kind of living at this kind of classification boundary, right? So these are really tough kids, tough cases. I think that this really elucidates this kind of, this threshold for the most is essentially arbitrary and based on clinical judgment. And so that's one place that makes early identification extraordinarily challenging. Now, with regard to kind of variability and phenotypic manifestation over time, I point you to a couple of these are both very short perspectives, editorials. One by my colleague Stelios, and actually a colleague of Amy Essler's here, Summer Bishop, I have this very nice paper on chronogeneity. And if this were a normal case and we were going to have lunch and I would tell some stories about how these papers came to be, and when a common colleague, Lonnie Zwagenbaum, told Stelios and myself that we were both working on the same idea at the same time. It was kind of fun. With some potential solutions to these challenges, okay? One solution that I want to put forward is an approach that we've implemented here in collaboration with Suma, Jacob, and Jason Wolf, and a number of additional colleagues, including folks in computer science and psychology, that we call Pheno Screening. And we just published kind of our pilot data that was a proof of principle for this approach that essentially anchored the R01. The paper was led by Colleen Doyle, a graduate student working with me. But we're thinking of this as kind of as a developmental approach to research domain criteria motivated sampling. So how do we select samples? Oops, sorry, or screen for samples if we assume that this diagnostic category is kind of, or remaining agnostic to DSM categories. If we're saying that autism is not a natural kind, but yet we want to study autism in a meaningful way. Well, there are a few assumptions about this approach. One is, like I mentioned, autism is not a natural kind. So what we're going to do is we're going to try to create, identify risk profiles based on behaviors that parents report on, okay? So these are going to be risk profiles of strengths and areas for growth in kids. And there's going to be more than two, more than a kid who's doing fine and more than a kid at risk. There's now, in anchoring that is this assumption that these profiles are going to be determined by variable aggregation of continuously distributed quantitative traits, okay? So one child may be showing very few stereotyped motor mannerisms. Another child may be showing a lot, okay? And what we need to do is be able to characterize the presence of stereotyped motor mannerisms in a more precise way than we have in the past, right? In order to get these kind of precise profiles of behavior. Right, and so that leads to this next bullet point. So the characterization of these traits or features should approximate biologically plausible dimensionality. Okay, and I know that probably, it's fairly abstract, but hopefully you'll know what I mean when we get there. But one point is that I know that some of you may be familiar with the ADOS, and which is the Autism Diagnostic Observation Schedule. It's the gold standard for diagnosing autism. And I think unwillingly, the developers of the ADOS kind of created a calibrated severity score because people were using raw scores to kind of estimate some degree of severity kind of inappropriately, but they derived this calibrated severity score. The scale goes from 1 to 10. And if you receive a calibrated severity score of 4, there's a high likelihood that you're going to meet exceed the diagnostic threshold and meet diagnostic criteria. So that begs the question that if you don't meet diagnostic criteria, we have a scale of 1, 2, or 3 to represent all the remaining dimensionality in what the ADOS measures. And now again, it just points to like the ADOS wasn't designed to characterize meaningful individual differences in people who don't receive a diagnosis of autism, right? And that's one of the points too that I'll return shortly. So here we want these traits and features to approximate biologically plausible dimensionality. And then lastly, we have to expect that our method needs to be able to handle the kind of asynchronously sized groups or clusters or profiles. You might have a very small profile that's very unique. Another, you might have, a classic autism profile if there is such a thing, which I think there might be. But so this is kind of a figure that what it looks like. We're going to be using a few parent report instruments that I'll talk about. We start with the community sample, and we parse these kids into some profiles that characterized by their strengths and areas for growth. We're going to check kind of the internal validity of these profiles, looking at the variables that we use to parse the kids and cluster the kids. And then we're going to check the clinical utility with a separate assessment of these groups of kids. So what this looks like with regard to and I'm going to come back to the RBS, EC, VR, RSB, and CDI. These are abbreviations. The repetitive behavior scales for early childhood was developed by Jason Wolf and is designed specifically for young kids and also designed to be able to capture dimensionality across the diagnostic threshold. So whereas the RBSR was really, which is the parent kind of interview or sorry, questionnaire that we would base this on, that Jason based this on, was really designed to characterize topography of repetitive behaviors in individuals who are diagnosed with autism or intellectual disability. And the VR-RSB I'll come back to as well. It's a downward extension of the SRS, the Social Responsiveness Scale, which is among the most widely used informant report measures in autism. So this is a busy slide, but I just want to point you to a few findings. So the top row essentially was kind of the first factor this approach. We implemented this, some analytic strategy called the factor mixture model, where we have all of these kind of features that feed in, and we derived a couple of factors, and then the clusters are derived from the factor scores. But then we look back at the variables that went in. And what we love to see here is this complete stratification of our groups based on their, in this case, restricted interests or restricted patterns of play. Now, these are all 18 to 25-month-olds, and the starting sample was about 1,560 kids. We're also getting pretty good stratification on rituals and routines. These behaviors at this age are also referred to as just right behaviors and are thought to presage some aspects of pediatric anxiety. We're also getting some stratification, not as strong with regard to kind of the self-directed or self-injurious domain, and this is repetitive motor. Here is our social factor. This is your gestures, these are words produced, and this is our social responsiveness measure. So higher score here is not good. So it's fewer reciprocal social behaviors. So one thing to point out here is we have this very small cluster. If we look at kind of what we think of as potentially high risk clusters, and we add them up, we're going to add up cluster 2 and cluster 4. We get 17. That's about 1% of our sample. So which is good. This is something that we were looking for with regard to kind of epidemiological estimates. Now, interestingly, this very small group here, they're showing the highest repetitive behaviors across the board. They're also showing the fewest amount of reciprocal social behavior, but they're also showing the most gestures and the most words produced. And there are 2 girls in this sample. And we think that this is kind of one of these scenarios where you get a girl, a 20-month-old female who has some language, but some other areas for growth that are kind of obfuscated or camouflaged because of their strong language skills. But that's yet to be kind of fully elucidated. So we're happy to see this kind of internal validation. And then our external validation, we use the ITSE, the infant toddler social emotional assessment, and that measure has kind of been validated against the CBCL, and we're showing some stratification. We had to combine our high risk groups by nature because of sample and because of power. We're showing some stratification, so we're happy about this. We think that this profile has, or this strategy has some strengths. So, and some of these strengths are kind of the context specific. It doesn't assume, we're not assuming universality, okay? These profiles are derived from the sample that you select, okay? So I'm implementing a kind of a sister study right now with the postdoc and some colleagues in Kampala, where we've had to go through and work through cultural specificity with regard to the items. But the rest of the approach should work because we're comparing kids to their same age peers. Okay, we're not comparing to some Western norm here. It's all self-contained and context specific. Now, okay, so that's one strength. It does not assume a binary outcome. As I mentioned, I think this is really important. We're going to have, and this leads to this idea, next bullet point, where it aligns with some goals of precision medicine. If we're kind of getting a bit more specific clinical recommendations, targeted, kind of not necessarily individualized, but individualized so much as within this profile, we think that that's going to be good. And so one vision is that a pediatrician gets the results from these analyses, and they say, okay, Bobby, you're going to go directly to speech language. That's your the profile determines that you have some strengths, you have some areas for growth, and let's get you into speech language rapidly. Here's another profile. Let's not even do a level 2 screener for autism. Let's get you signed up for a diagnostic workup as soon as possible, and so on. Here, this other child will go to physical therapy. They're showing some motor development delays, so on. Data-driven aligns with goals of precision medicine, which I'll return to at the end. Now, I wanted to come back to context just to kind of hammer home the point about autism as this thing that exists in nature, and probably a bit more think about the kind of origin story of autism, right? I mean, and I think when you have that historical context, it should make it easier for us to say that, okay, yes, maybe autism isn't this singular category that exists in nature, and we should be thinking about it in a more complex way. So yeah, just a very brief interruption for some history, because I know that this group is a curious group and will probably appreciate this. So this is 1942. Foster Kennedy is at Cornell, and he's the president of the American Neurological Association, so a major figure in the field. And so this is the editorial statement. In this issue of the journal appear 2 papers dealing with the attitude of society to the feeble-minded, one by Dr. Foster Kennedy, the other by Dr. Leo Connor. For a specified group of defectives and under specific conditions, Dr. Kennedy advocates euthanasia. Dr. Connor opposes this procedure. So this is a remarkable exchange in American Journal of Psychiatry, 1942. I mean, just imagine Connor doing observations and keenly observing behavior beginning around 1935, building some case histories around these behaviors during this context, this climate. And it's remarkable to think about his courage and will. I mean, at the time, he's also trying to merge the disciplines of psychiatry and pediatrics, and he wrote the first child psychiatry textbook in 1935. And he's still a pretty young guy. This is just really remarkable to think about what he did for kids with autism, not just to give their profile of strengths and areas for growth a name, but it's almost, I don't think it's totally bombastic to say that he's saving lives in the work that he was doing. But you can imagine, this is more context for thinking about how autism came to be a disorder. So yeah, 1943, he publishes this seminal paper. Okay, so I'm going to go pretty quickly over the next few slides. I'm going to really kind of focus in on some aspects of measurement. And this is something that my lab has been working on intently for the last several years. So returning to this key assumption that the characterization of traits and features should approximate biologically plausible dimensionality across the diagnostic threshold. So this is a figure that maybe many of you are familiar with. This is from, or a variant thereof. This is the SRS, again, the most widely used informant report instrument in autism, designed to characterize, to some degree, a kind of a singular quantitative autistic trait. Subsequent factor analyses and big samples have revealed kind of these 2 underlying factors. But nonetheless, I think John Constantino, one of the developers, talks about it as kind of this quantitative assessment of autistic traits. So there's 22,000 school-age kids from Japan. And what you should be looking for here is kind of the sex difference that is present in autism. A higher proportion of females have lower scores. A greater proportion of males have higher scores, okay? But the other thing to note is this nice dimensionality. And so here's data from our lab on 1,700 18 to 24, 25-month-olds, and we get the same pattern. A greater proportion of girls have lower scores, and then the black bars are higher for boys in the higher scores. So we were happy to see this pattern. And again, the dimensionality is something that we're striving for here. And we followed up some of this work with my collaborators at WashU, Natasha Maris and John Constantino, where we combined forces with my sample and a sample of twins that they've been studying, and implemented some strategies to look at the psychometric integrity, but also heritability in this metric, in these metrics. These are our data from Minnesota. These are data from about 600 twins from WashU and then a site in California. This is showing associations between just kind of zero order correlations between 18-month reciprocal social behavior score, 24-month, and then again 18-month and SRS score measured at 36 months. So we seem to be getting close to a downward extension of the SRS, which we're really happy about because it's marking some degree of this dimensionality that we're hoping to capture. And we've done similar work with the repetitive behavior scales for early childhood. So this initial paper did a factor analysis, looked at the factor structure, and did some other analyses of checking on content validity. And this was in a sample of about 900, and kind of nice kind of anchor to our use of the repetitive behavior scales. And again, now this is what was so compelling, was the distribution of repetitive behaviors in the sample, again, for like 18 to 25-month-olds. We'd never seen something like this characterizing repetitive behavior, a shape of a distribution like this. So what this means to us is that we might be able to approximate this kind of dimensionality across the diagnostic threshold with this measure. Now, we don't ever do analyses on kind of a combined sum of repetitive behaviors because we know that they're different, and so we want to look at them independently. But this distribution was great to see. Now, we've done other work on these measures, and what I want to mention now is much of this work is on typically developing kids, because we want to establish some psychometric integrity and characterization in typically developing kids before we move on to thinking about population-based screening with any of these or characterization of deficits in young children with autism. So more work from my graduate student Carolyn, where she's examining kind of criterion-oriented validity for both of these new measures. Very nice paper. Again, showing one interesting finding kind of broader outside of autism is showing that these higher order repetitive behaviors, thinking about insistence on sameness behaviors, rituals, and routines, are associated with aspects of internalizing, as measured by the ITSE as young as 24 months of age. And we've also shown some hint of clinical relevance. We're showing that work from another graduate student, Robin Sifri, showed that infants who were born small for their gestational duration were showing subtle differences in repetitive behavior and reciprocal social behavior. So the next question is, can this approach be downward extended to the first year of life? Okay. Well, first we have to establish longitudinal measurement invariance, among other potential sources of invariance, to combat kind of these variants of detached validity claims. So this was another kind of learning objective, so that for those of you who'd never heard of a detached validity claim, hopefully you take away from this knowing what that is and why it's problematic. But essentially, this is the presumption that an instrument or a measure validated in one context will perform equivalently or maintain the same psychometric properties in a different context, okay? At a different age, with a different sample, so on and so forth. Essentially, we need to remember that reliability and validity are not inherent attributes of a given instrument, but they're bound by a context and a sampling frame. And so this is taken into consideration. Measures of depression in young kids may ask about, crying, and it may be algorithmic for boys, but not for girls. That's kind of the classic kind of case example. What we use in our work is mouthing objects, which is going to be very common for Michael Paul's young 6-month-old. It's a very common exploratory strategy, okay? That will diminish over time and give way to other exploratory strategies. And so for us to measure if this is an item on our repetitive motor scale, we want it to be, we need to determine whether it's useful across the age that we're studying. And here, so we're looking at differential item functioning across some moderator, which could be age, could be sex, it could be culture, it could be case versus control, right? So to see if these items work the same in across all these groups. Okay, and here's the paper if you want to go to it. It's long, but it's wonderful. So just I'm going to speed up a little bit. I hate to do this because I love this paper, but this is our kind of where we were implementing kind of the cutting edge measurement and variance model. We even have, and this is work led by Robin and with some important contributions from my colleague Dan Barry. We even have a section in here, kind of what is measurement and variance and why should we care? And it's a really nice paper, a nice demonstration of this technique, but also yielding important findings. So this is the method. Again, if you're curious, ask me about it in the questions, but I'm going to move pretty quickly because I'm short on time. So we can test for multiple covariates at once. Importantly, it's accounting for both the latent factor estimate and the differential item function as a function of a given covariate. It has some strengths over some other models. People are familiar with like a mimic model. Other perks is that it's increasing normality. So here's what the raw scores look like for this kind of higher order domain of repetitive behaviors, but the adjusted factor scores yield a beautiful normal distribution. This is what raw scores look like for repetitive motor and self-directed behaviors. This is what the distribution looks like for repetitive motor for adjusted factor scores, and here's self-directed. If we plot all of the time points here, you can see differences in what the best fitting lines for the data according to kind of the adjusted score here. And this is a model with the raw means. And then we can differentiate sex based on some of these trajectories of change as well. So this was a sample of about 180 kids, 606 assessment time points. So we feel like this is something that is going to be an ongoing strategy for us. Everything new that we do. We're going to have to do this again when we have a sample of kids who are at high risk for autism. We're going to need to do this again when we have cases of kids with autism. But we need to ensure that there's invariant functioning across these cohorts and these groups and across age. We're also, Casey Burrows is working with our group, has a new K award to implement these models to look at sex differences, for example. So what do we know? I'm going to transition now to kind of quickly to findings from the familial risk paradigm. So what do we know about autism in infancy from infancy? If we need to get down to kind of pre-symptomatic or strategic prevention, we need to get to infancy. So importantly, there's no direct observation. There's no kind of overt behavioral markers of autism at 6 months of age. We've been looking hard, but there are zero overt behavioral markers of autism at 6 months old. Now, what I'm highlighting here are all eye tracking studies. If you use eye tracking or EEG or MRI, there seems to be some signal, but there are zero overt behavioral markers at 6 months of age. At 12 months of age, there are a number, and I've listed them here. And I highlighted a couple: inconsistent or lack of responding to one's name, and deficits in responding to and initiating joint attention, because these have both been identified at 9 months, okay? Aspects at 9 months, and this is recent. These are the first overt markers of autism in children under 12 months of age. So the first was this response to name, led by Megan Miller and Sally Osnoff. And then this group in Sweden, Turja Folkeder and Parnystrom published this paper showing a difference at 10 months in initiating joint attention. And then we have a paper that was just accepted, led by Isa Stallworthy in my group, showing that responding to joint attention differences responding to joint attention differentiates high-risk infants who want to develop autism from those who don't as early as 9 months. This is the strategy that we use. Again, the one kind of theme of my talk is kind of thinking about measurement precision, both quantitatively, but also conceptually. And here is a task that I developed as a graduate student where I was trying to reconceptualize joint attention as a performance that can vary rather than a competence to be acquired. And when doing so, if it's a competence, the individual variability metric is simply the age at which you acquire it. If you're thinking about performance, then you might be able to tap into some variability in similar aged kids, right? And beyond kind of the age at which you're doing the most sophisticated thing. So we do this by varying the Q redundancy of the bids and by generating a score based on their responses. These are what the data look like. It's showing this is a combination of data collected in my lab on typically developing kids and the IBIS group, looking at high-risk kids who want to develop autism. And what we're showing here is at 9 months of age, as early as 9 months of age, the kids who want to develop autism are showing much lower or responding to joint attention sophistication than their same age peers. So other important leads come recently that are going to help us get to this strategic prevention approach is this kind of work on parent report. And this is a measure called the Apse, and it's showing some signal as early as 9 months, but even greater or as early as 6 months. A disorder-specific effect at 6 months of age. And again, this is in high-risk infants who want to develop autism, so high-risk ASD. And the red is high-risk negative, kids who don't want to develop autism and low risk. So there's some signal even as early as 6 months. But at 9 months, they followed this up to look specifically and at kind of screening classification, the potential for this measure. And these are the items that came up that differentiated the groups in the way that you would need. The last two are ones that didn't survive correction for a family-wise error rate. But the positive predictive value and negative predictive value of this measure look pretty good. And again, these are in high-risk kids. So translation to general population is yet to be determined, but it's something that we're very interested in testing. So the last kind of important lead, some evidence coming from the IBIS group. This is the infant brain imaging study, and I just want to do a quick plug for this. There's 5 sites around the country recruiting infant siblings of children with autism. We're currently recruiting and ready to see babies if you know families who are interested. We do behavioral assessments, essentially monitoring the younger sibling as they grow up, but we also do brain imaging. And we had kind of a paper that appeared in Nature a couple of years ago, and I don't have a couple of slides on this, but essentially, you know, the figure on the left kind of clarified a long-standing kind of 25-year-long mystery in the autism field about the timing of brain overgrowth in autism, and essentially showing that at surface area expansion between 6 and 12 months predicts the total brain volume overgrowth observed at 24 months. That's a consistent finding in the field. And so clarifying that timing was a big deal. But then we did kind of a proof of principle analysis where we used deep learning to classify kids, whether they received a diagnosis or not, based on their cortical features at 6 and 12 months of age. And what I wanted to point you to here is this positive predictive value of 81%, negative predictive value of 97. So essentially, we're predicting with individual level specificity who's going to go on to develop autism based on the brain findings. And there's more about this story in this review paper, if you're interested, that I wrote with Joe Piven and a basic scientist, Mark Zilka, in a few years ago, describing kind of early brain behavioral development in autism. And you can also learn more about the IBIS study at this website. So what does the future look like if we're able to pull all of this together? It might look like something akin to a Pheno Screening approach implemented in very young children, where we kind of can do high throughput data collection through parent report to select kids for a level 2 that could involve our imaging modalities. Now, I know that imaging is often assumed to be not scalable, and why would we ever think of this in the same conversation as screening? We've actually written a paper on kind of the cost effectiveness of MRI-based identification in the high-risk cohort. But at the same time, we have colleagues at CMRR who are developing portable MRI. And the expectation from my standpoint is that if a technique is effective, costs will come down. And what's happening right now is we are pushing the technology to make it available to hard to reach communities, and communities that had historically been had not had access to an MRI. So some closing remarks. Can we do better than precision medicine? Okay. It's a grand goal, precision medicine, but it's reactive. It's reactive to a consolidated phenotype. The motivation for my title comes from this paper from Tom Insel and kind of trying to push us, right? And so this idea of cure therapeutics and strategic prevention. In order to get to strategic prevention, it requires discovering incipient or instantiating pathophysiology. And in this little editorial that I just wrote, I kind of took a rather militant developmental stance on what needs to happen in order to identify instantiating pathophysiology. Is in part, kind of the one take home is we can't assume that instantiating pathophysiology will be stable and persistent and observable throughout the course of a disease or disorder. Okay, so we have to study it at its origins. So in conclusion, if we reconceptualize autism as a variable aggregation of quantitative traits, clusters, profiles, if you will, if we attend to measurement invariance and measurement precision, sprinkle in some creativity and secure funding, we might be able to enact some type of proactive precision medicine approach that identifies incipient risk profiles and then targets preemptive intervention. And so what does preemptive intervention look like? Stay tuned. You're going to have to invite my colleagues Jason Wolf and Jessica Simacek to come give a grand rounds in a couple of years. But until then, thank you for your time. This is my lab. They're fantastic. I wouldn't have any data to show you if it wasn't for them. So thanks to them, and thanks for your attention.
Well, thank you so much, Jed, for a really fascinating talk and tour de force through all the work that you've done and the history behind it. It's really very wonderful to hear that. So we have some time for questions, maybe about 20 minutes or so. We've already got a few questions, both in the chat and the Q&A. I'll encourage people, anybody who else has any other questions, please go ahead and put them in the Q&A, and I'll try to read them aloud, summarize them, and deliver them to Jed as in the order that they're written. So the first question that was in the chat near the beginning of the talk, so are these societal costs of autism based on the cost of intervention, or are they based on other metrics like productivity loss or other kind of larger economic factors? I think is the kind of general.
Yeah, all of the above. All of the above. Kind of total. You can look at costs based on you can look at education, you can look at medical, you can look at societal, and again, I'm peripheral to this line of inquiry, but my understanding is that those costs are estimated from kind of all of the above: total costs, loss of productivity, cost of intervention, cost of additional medical, emergency room visits, costs of loss of productivity of caregivers. So, yeah.
Another question, Jet, does the patient advocacy need diagnosis equals service and IEP access also play a role? I think this was kind of early on talking about kind of some of the, I think this is just after the kind of cost discussion. I don't know if that was from Alec Widge, if he wants to provide any other kind of clarification to the question. Oh, here it is. And does it play a role in the heterogeneity specifically? So does the patient advocacy need needing to advocate for a diagnosis to get services in IEP, does that play a role in the heterogeneity that is seen in autism? Kind of, some people are better able to advocate for themselves than others, perhaps.
Yeah, that's really interesting. I hadn't really thought about that. But certainly, yeah. If we don't have Yes. If we have an advocate, so one of my best friends has twins, a girl and a boy, and boy has autism, and she's a fierce advocate. And if she hadn't have been early in life to get the services that her son got and the language gains that he made, life would probably be different now, and he would be presenting a different phenotypic profile now. So it's kind of a combination between the temporal heterogeneity. And when in my little piece on temporal heterogeneity, I mentioned this kind of changes in environmental constraints over time, right? That can have exert influence. And that would clearly be one of these influences. Yeah, that makes a lot of sense to me. Good question.
Yeah, and I would echo that in my own experience. I have a family member, a cousin who has a son with autism who, yeah, the need to advocate to get the kind of things in the IEP that, you know, the level of specificity and tailored to his individual needs, I think is, you know, there's kind of an interplay between the needs of the individual are already specific, and then if you don't have an individual IEP that's tailored to those specific needs, then their outcomes probably are going to be very different than if you do have that kind of specialized attention in the classroom. So we have another question in the Q&A. What can we do with the population that seems to have taken care of their child, finally bringing their child in at, say, age 18, and this is suggesting in areas such as African populations?
Yeah, I am not sure I have the answer to that question. I mean, one thing that is happening, I think in part of the kind of, when we talk about better case ascertainment, one thing that's happening is more and more individuals are being diagnosed as adults. I was just communicating with somebody who was diagnosed at 18, and she is excelling, at least in academically, in a very prestigious undergraduate institution, but has her challenges that she deals with on a day-to-day basis. So, you know, this is, I wish I had a good answer. There are more researchers, and some here, who are thinking about this transition to adulthood and the challenge that is faced by older adolescents, especially as they may be leaving the support system of schools. I know that Suma's thinking a lot about that, and Becky Hudak in pediatrics, and Amy Essler. So there is an increased effort to think about kind of either first diagnoses at age 16 or 17, and then thinking about how to support those individuals through the transition to emerging adulthood. Now, the other point that you bring out are kind of cultural differences in background, and that's another challenge in how we deal with that. And it may be that, and like the first part of my answer, I don't have the answer to that question. One strategy that I'm thinking about is we need more representation and training of individuals from those cultures to be able to help answer those questions, because I'm not going to presume to understand, you know, the cultural nuance and mores in order to make kind of specific recommendations in that regard. I currently have a postdoc. Was fortunate enough to have a postdoc from Ghana, and we've been collaborating on this work in Uganda, and he's back in Ghana now, and we're trying to continue to build some neurodevelopmental screening infrastructure. But this is all brand new for me, and he's kind of holding my hand and leading me along the way. So you know, maybe we could follow up on this when we know more, perhaps. Sorry if that was not satisfactory.
I would say it probably also speaks to the need for the kind of work you're doing, looking at measurement and variance, things like this, to say, these tools that we have, how broadly applicable are they? Can they be used in other cultural contexts? other languages. You mentioned you were doing some work. I'm sorry, where was it? Was it in India?
In Uganda.
Looking. Oh, that was in Uganda. Oh, so this is, I see. This is I see. You had mentioned that during the talk.
Yep. And so we collected data on a bunch of these measures, and we're looking at it. We're gonna examine measurement and variance. And so one measure in particular that I mentioned at the end that seemed to be showing some promise, the Apse, the Autism Parent Screen for Infants. We collected as part of our new R01 with Summa. We have collected, over 1,000 data sets on that measure from 18 to 24-month-olds, and that was a measure that we implemented in Uganda. And a couple of items didn't survive the translation, like culturally it didn't make sense. But it's still, we ended up, I think we have data from about 250 families, which should be sufficient for us to look at some of these questions of invariance. And my anticipation is that it will be invariant, or it will not be invariant. And so then we need to go back and fine tune, right? And we need to fine tune. But yeah, we're testing some of these questions, and I'm excited to see what comes of it.
Yeah, if it's not invariant, which questions don't apply, or which questions show the biggest variance, and then how can you refine those to kind of achieve that invariance?
Yep,
that's great. If there are any other questions, please let us know. One question I was interested in is the kind of cost effectiveness of the brain imaging piece. Of course, that's kind of a major area of interest for me. And I wondered if you could say more. I wonder, you sort of alluded to this, I think, probably early on in talking about the cost of some of the early interventions, which can be very expensive, but then does that early investment of that kind of intense cost in early intervention defray a lifetime cost, or help offset a lifetime cost of kind of poorer outcomes for those kids? I wonder if it's a similar kind of argument in terms of imaging, whether an relatively expensive imaging procedure might be used to identify a child early on, and then an insurance company might be motivated to pay for that if that is going to help with long-term outcomes.
It's a very straightforward question. Yeah, if you have sensitivity and specificity, given metrics of sensitivity and specificity from a given tool, and that will increase the likelihood that a child will get into early intervention before age 4, then we have subsequent kind of cascading effects on total accumulated costs. So that's the argument that we make in the paper, is that's how you determine cost effectiveness, right? And so we have to have pretty high specificity, but I think we're almost there in the high risk case, in high risk families. But translating it to the general population is going to be, something that we're going to be pursuing. So we'll see.
That's great. We have another question. Actually, 2 more questions. Are there any data bearing on whether early intervention alters the incidence of later psychiatric disorders, such as psychosis, catatonia, mood disorders in late adolescence or young adulthood in ASD? Or is that field too new to answer this question?
Yeah, I love that question. And I'm going to go look. I don't know. I don't know if the answer, but I'm going to go find out, because that will have like direct bearing on a grant that I'm writing, if that's the case. So one thing that we're thinking about is, there's the SRS that we talked about, and one of the measures that we're very invested in is a downward extension of that. The SRS will differentiate kids with ADHD from controls. It will differentiate kids at clinical high risk for psychosis from controls, kids with early emergent psychosis from controls, kids with disruptive behavior disorders from controls, kids with various forms of anxiety from controls. Okay, that body of literature, combined with some data from a couple of massive twin studies and registry studies from Sweden, that identifies increased autistic traits across all, when we used to have all Axis 1 psychiatric disorders. So one thing that I'm thinking about is, it's kind of like, here's the autism researcher telling us how important autism is, for all the stuff that we do. But one thought is that if we do well in this population-based screening, some of these profiles may not be autism specific. Maybe they could be kind of signs of early emerging anxiety, for example, is one domain that we're thinking about with some of these just right behaviors and rigid adherence to routines and so I'm thinking about that a lot, but I don't know the answer as to, I don't think that there's evidence to suggest that the early interventions have knock-on effects on subsequent comorbid manifestation of these other profiles.
Well, that question was from Dr. Steve Olson, so possibly something you two can follow up with.
Yeah.
This one from Dr. Lydia Zlowska. Are you planning to look at clusters of behavior predicting autism? Are you also noticing patterns predicting other common comorbid conditions such as ADHD? So kind of similar in flavor there.
Yeah, this is good. So we want kind of, what we need to do is we need to balance between, we have to do better than a 20-item yes/no questionnaire, right? But we probably can't do more than like an hour of questions for families if this is going to scale, right? And I don't even know if it's going to work, if it's going to scale. The way that we get it to work is we pay families. We say, please fill out 45 minutes worth of questionnaires, and we'll reimburse you. And if I could get insurance companies on board to say, look, if they give us this, you'll send them a kind of a carrot, a little refund or something like rebate if they do this, we might be able to do it. But we have to balance. So we had some hard decisions to make about, and we wanted to really focus on kind of the family of how for early identification of autism and kind of maybe language delay, some subtle motor impairment maybe. But there are people working on these features for early characterization of ADHD. Megan Miller, I mentioned, she's at UC Davis. I think she's like leading the field right now with regard to a field of like 3 people trying to look at familial risk for ADHD in infants. And so it's very exciting. We have not, I don't feel like we have the measures. I don't feel like we have the items that would characterize kind of ADHD symptomatology in a 2-year-old or even a 2.5-year-old. But it's something that we, hopefully soon is still on and will help me remember that we need to have this conversation.
Well, I'm not seeing any other questions, so go ahead and thank Jed again for his time and for his wonderful presentation. And I'm sure that if anyone else wants to follow up with you, you'd be happy to continue conversations offline. All right, well, thank you all for attending, and hope you enjoy the rest of your day.